And I'll start out, you highlighted that the TKI versus ADC, kind of they're both next to each other, and that in the future, probably moving them up. But how do you decide between them? What is your expectation about sequencing of those two themselves?
Yeah, I think this is a really good question. I think what's nice, and this is actually a theme that's continuing to emerge in non-small cell lung cancer, is that we have options, right? We have options for our patients. So I think this is an opportunity not only to think about the biology, but to lean in on those patient preferences and factors, right? So one is an oral route of delivery, another is coming in every 3 weeks for an infusion. And the toxicity profile, right? If you pull up the toxicity profile, I'm constantly thinking about that. Am I worried about if the patient has LFTs already at baseline that may be concerning? Am I worried about a higher risk of ILD or pneumonitis developing? Am I worried about cytopenias? I'm thinking about all of that and discussing it with the patient. So it's an opportunity for informed and shared decision-making based on toxicity profile, and also that intracranial activity and efficacy, I think, is also a big one to be thinking about.
May I ask another question? So you are at MD Anderson. How is the organization at MD Anderson for testing for HER2 with immunohistochemistry?
Yeah, I think this is a great question. And if you don't look, you won't find it, right? And we don't have reflex testing. At most, our reflex testing at my institution is PD-L1 IHC, and that's it, and that's variable. And so I have started, and many of my colleagues as well, almost ordering a starter welcome pack for patients with non-small cell lung cancer. So yes, we get the NGS, yes, we get IHC PD-L1, but I'm also routinely now ordering if there's enough tissue, HER2, and CMET. So that's my welcome pack, if you will.
And if there's not enough tissue?
There's not enough tissue, the priority is NGS and PD-L1.
Yeah. And then when are you getting HER2 testing then?
IHC?
Yeah, IHC.
Ideally up front.
I'm assuming you're getting biopsy.
Yep.
Again, the question, I guess, is more directly, are you then getting a biopsy before initial therapy, or are you kind of considering that for future to make sure? And then, of course, you got to keep track of whether or not you ever got it.
Yeah, so these are all great questions, and I bet you if you asked each of the people in my institution, you get a different answer, right? And if we went to different institutions, same thing. So if up front there isn't enough tissue, I usually won't push for another biopsy just solely for IHC for HER2, but it's definitely on my radar. It's flagged in my note, it's bolded, it's red, it's super important. I think that's a whole nother topic about just EMRs, keeping track with NGS results, making sure that the results that are there on NGS are translated into clinical and meaningful practice is also really important.
And I think an important thing to remember is, of course, we all have patients who have been managed on first-line therapy that didn't have this testing previously at baseline because it wasn't really the option then, although it's been a while now, so I think for many it is. But remembering that as the field changes, that these patients were going back and looking. So, you might have patients on third, fourth-line therapy. Did they have HER2 IHC testing? So we have time for discussion, so do please submit any questions from the audience. I want to start out with the EGFR space has become quite a bit more complicated now, which is exciting. There's so many different options. How do brain metastases within that space in second-line therapy? Obviously, whatever you've had in the first line is going to influence second line, but how do brain metastases in particular influence your decision-making in that space?
I think that I don't decide just based on the presence of brain metastasis. I just decide with the overall picture of the patients and how quick we want to obtain a response and how aggressive we want to be with the patients. So I think that how to sequence, and now starting from the first line, clearly everything that you do is dependent on what you do in the first line. So if you start, for example, with lazertinib, amivantamab, I think that Dato-DXd can be a fantastic second line, or SACT when will arrive also in the United States. And then if you start instead, like in this case with osimertinib, I think that the second line is dependent on also patient preferences, because we know that they have a different toxicity profile. And remember also that the data that we have are on patients who had received already TKIs and chemotherapy for TROP2-LUNG05. So I think it's multifactorial. I think that doing another biopsy is important because, for example, if you find the MET amplification, this can be another option again. And I think that the discussion with the patient on the possible side effects, I think that is important as well.
Excellent. So, Eric, I'm going to come back to you because something you discussed in your talk is relevant across these, and that's the interstitial lung disease.
Yeah.
I feel like this is a more complex topic than what's often discussed.
Right.
Of course, it's something we need to watch for, but I also worry that, I see patients with waxing and waning inflammatory findings in their lungs all the time. And when they're not on one of these drugs, we don't call it a drug-induced ILD. Right. If they are, then there's then there's like a rush to do that. And so I feel like it's something we need to watch for, but then once you find it, it's something you need to look for everything else and consider how are you managing that? What's your process?
Yeah, you're highlighting, I think, a real conundrum in clinical practice right now. And it's really tough, to be honest with you. It's almost like this bias of you're worried about and you're so vigilant for it that if you keep looking and you're getting those scans routinely, you're going to find something, whether it's grade 1, right? And then what do you do? I'm very fortunate at my institution to have amazing interventional pulmonologists who help me help my patients. We have a world-renowned expert just focused on ILD and pneumonitis from drug-related toxicities, and he's incredible. I pick up the phone, I talk to him all the time. And so I think really it's all about education, honestly, for the patients, making sure saying, hey, this is something I'm really worried about. Do not wait if you're starting to feel short of breath, if you're having chest pain, please let me know. I want to know earlier. And the education for my nursing team, oftentimes we're not the ones, right, as medical oncologists that get that MyChart message, that get, the phone call saying, hey, something doesn't feel right. It's the nurse. And so I really educate my nursing team and my APP and say, hey, listen, this is a potential toxicity. This is a real one. And it's different, right? It's different than pneumonitis from immunotherapy, that flare, that what you need to do is very different. It can be very challenging. So I wish I had the perfect answer, but I do want to say I have a perfect team and a team that's willing to help our patients.
Yeah, I mean, it's wonderful to have such an expert team. But so to drill in a little bit though, so grade 1, meaning that there's radiographic findings but no symptoms, versus grade 2, if there's even mild symptoms. Yep. Where's your line? And I realize you can't kind of draw a distinct line that works in every case, but just give us a flavor. Yeah,
so actually, if you look at the label for TDXD and what you're supposed to do, it's grade 2. Grade 2 pneumonitis, you're no longer able to continue. But what I would argue is that there is this varying spectrum of grade 2, and that's where I run into a lot of trouble. At my institution, I treat a lot of patients under the age of 50. Before we had some of these targeted therapies that were readily available, able to give patients, I had to figure out what to do, how to help navigate patients for a therapy where they were deriving efficacy, but I was worried about this potential toxicity. And I worked very closely with my interventional pulmonologist. Grade 3, of course, is that a patient often has to be admitted. They need supplemental oxygen. That's one where I'm very worried and probably unlikely to really re-challenge a patient with the therapy that's caused that. But grade 2, I'm definitely getting nervous. Even there's research now being done looking at grade 1. Should we start giving steroids at that point to prevent further progression, to keep patients on therapy? So I think it's an evolving landscape, but definitely grade 2, quite worried. Grade 3, extremely worried.
Yeah, I think that's one of the more difficult topics, and I trust that there are patients we are probably overcalling a drug-related ILD, while at the same time recognizing this is something we also need to identify early and retrospectively is more clear than prospectively. Dr. Garasino, QCS-NMR, you talked about that at the end. This feels like the forefront right now, not just for Dato-DXd and TROP2, but maybe more broadly, although we're still so early in this process. Can you just give us a look ahead? What are the data points you're waiting on? When are we going to kind of get next steps to this process to see where things are going?
Two answers. So the first is that the digital pathology is really exploding. So I think that this will be maybe the first biomarker, but maybe this will be not the only biomarker. So in the future, I think we will see even more this kind of automated systems, and maybe the pathologists will not have to count cell by cell to say how many patients, how many cells are positive or negative. So we should be prepared that this wave of digital pathology in general is coming. For the QCS-NMR specifically, I think we will see the data of Avanzar that will come hopefully during the year, and the QCS-NMR is incorporated already in the endpoints. So I think to have something that will help us to decide, I think the only part is that we should get used to incorporate something that is not out of our comfort zone in our practice and see how we can implement this in our daily life.
Can I ask you a follow-up question? It sounds like it's very complicated and technical. How do we use and get this technology out to not just academic centers, but community practices?
So this is a device, so it's not something that we have to invent in our clinic. So this is an automatic system with a patent, with a specific score. So I think that the problem is to help the pathologists to incorporate the tool in what I think is important is that we will be aware that we don't need supercomputers or we don't need big data centers to do this kind of tests, because maybe there is the misperception that if you don't have the biggest supercomputer in the world, you can't test. So this is something that will be spread.
Yeah, I mean, as amazing as the technology is, how high-tech, it's pretty straightforward as far as the implementation. And I think there's already an implementation plan for this that is, the rollout to this is not the problem. We have big data that's coming, though, in ongoing trials, and so I think we'll see next points from
There are also
Avanzar.
the data in the real world that were recently presented showing that the system is able to discriminate as well as the pathologist.